Hello everyone, today I am going to talk about a very important topic in neonatology, that is newborn jaundice or neonatal hyperbilirubinemia. So let's move on to the topic. As for today, we will be talking about neonatal jaundice. So in short you can write NNJ. So what subheads we will be covering is about bilirubin production and its metabolism insert. Then we'll be covering about the types of neonatal jaundice, how to clinically evaluate it. Okay. Then we'll be talking about Cornicterus, just insert. Then we'll be talking about the management, and yes, we'll be talking about important questions that can be asked. Okay, so probable question that can be asked during our exam. So now let's move on to the first subhead, that is bilirubin production and metabolism. Okay. So this is very important because everything we'll be reading behind will be related to this. So if you understand this, then it will be very easy to understand the whole thing regarding to neonatal jaundice. Okay, regarding the clinical evaluation, then management, everything. So for this we know. So how does bilirubin get produced? So where does bilirubin get produced from? As you know, RBC has a lifespan of 90 to 120 days. So it is when it is destructed, it is changed to heme and globin. This is recycled, whereas heme is converted into iron and biliverdin. Okay. So this biliverdin is now reduced. So the enzyme here is heme oxygenase. You should be remembering this name. Okay, heme oxygenase is important in management aspect also. I will talk about it later. So biliverdin is converted into bilirubin. So which bilirubin is this? It is conjugated or unconjugated? Yes, it is unconjugated bilirubin. So the enzyme involved here is biliverdin reductase. So this unconjugated bilirubin now is transported to liver. Okay. So how it is transported? It is transported by albumin. So this albumin and bilirubin will make a complex and they will enter the liver. So in the liver there is an enzyme, and you should know about this enzyme. Okay. So this is urinyl diphosphate glucuronyl transferase. Long name, right? So it has a very short popular name, UDPZT. Okay, so by the help of this enzyme, bilirubin is conjugated into bilirubin monoglucuronide and bilirubin diglucuronide. So now the bilirubin is conjugated. So tell me, this unconjugated bilirubin was water insoluble. Now this is made water soluble. So now from the right and left hepatic duct, So this is, let's say this is gallbladder. So this is common hepatic duct. So this is cystic duct. Okay. So this is common bile duct. So this is common bile duct. Now this will open to the second part of duodenum. So this will open to the second part of duodenum. So, my dear students, what you should remember here is like, so bilirubin, the conjugated bilirubin will come here. Okay. So from now what happens? So a part of it will go to the gut, will go absorbed to the gut and will be excreted as stercobilinogen in stool. Okay. So some of it will be going to the blood circulation, then from the kidneys it will be excreted as urobilinogen. However, am I clear? Okay. However, now some will go to the enterohepatic circulation. Okay. So what is enterohepatic circulation? In enterohepatic circulation, conjugated bilirubin is converted into unconjugated bilirubin. Okay. And will be again taken to the liver. Okay. So in conditions where interhepatic circulations occur, there is chance of hyperbilirubinemia. So if there is poor feeding, if the breastfeeding is not proper, so in certain conditions interhepatic circulations can increase and lead to jaundice. We should know that. Okay. So this was just in short about the bilirubin production and metabolism. Now with that we can move along to let's move to the types of neonatal jaundice. Okay. Yeah. So all of you know there are two types of jaundice, right? So one is physiological jaundice, the other one is pathological jaundice. So most of the times in exam we will be asked about these types of jaundice. Okay, there will be given a case scenario or something like that. I'll talk about it later. So the most physiological jaundice, this is the most commonest type of neonatal jaundice. Okay. So when does it appear? It appears after for 24 hours. Okay, any jaundice which appears within 24 hours can never be physiological. You should know that. Whereas pathological jaundice may appear less than 24 hours. Okay. I mean to say that. So for pathological jaundice, if any jaundice appear within 24 hours, it is pathological, but pathological jaundice may also appear beyond 24 hours. So now, and what happens is, clinically they never stain palms and soles. If you see a newborn baby whose palms and soles are stained, that can never be physiological. It is pathological and it needs treatment. Okay. So it can stain palms. Let's say can stain palms and soles. Okay, and the risk of colitis is high. Okay. Number 3, urine does not stain diapers. Well, urine is not high colored. So, but here there is high colored urine, and more importantly, stool can be clay colored. So always in the case of jaundice, you should always asking if the jaundice is if there is jaundice and the baby has high color urine and stool is clay colored, कमेरोको जस्तो हैन, कमेरो भनिन्छ, okay, कमेरो जस्तो. So how long it may persist? Okay, so generally flagellar jaundice they does not persist beyond 3 weeks. Okay, whereas they may persist more than 3 weeks. They may, okay, not all the pathological jaundice should persist 3 weeks, okay, but they may. If any jaundice persists more than 3 weeks, then you should try to find the cause, okay, because each and every pathological jaundice needs treatment. Okay, now what I am to talk about is Kramer's scale. So this Kramer's scale is gaining popularity because for every jaundice, drawing a blood sample and sending to the lab and getting a report can be tedious and may not be needed. The child may be landing in unnecessary infection. So Kramer's scale is gaining popularity because just by looking at the baby, we can assess the level of jaundice. So to make it more clear, I am drawing a picture here. Okay, so this is the umbilical level. Okay, this is the level of knee. Okay, okay, now let's divide this picture in zones. So this is zone 1, head and neck, okay, and zone 2 up to umbilicus. Okay, so up to umbilicus, let's say this is head and neck. Okay, so let's say this is up to umbilicus is zone 2, and zone 3 is up to the level of knee, that is zone 3 up to knee level. Then up to the level of ankle, this is zone 4, and palms and soles, okay, palms and soles is zone 5. This is palms and soles. Okay, so how do you grade? So if it is zone 1, then the bilirubin level in mg per dl, okay, is 4 to 6 mg per dl. So it is zone 2, then probably it is 6 to 8 mg per dl. So there might be different classifications, but this is what it is which is followed now. So you should be knowing about this. Zone 3 it's 8 to 12, okay. So zone 4 is 12 to 14, and zone 5 more than equal to 15, okay. So about Kramer's scale, this is the thing. So you should be knowing about the classification into different zones and at which zone what is the bilirubin level. So now we have clinically evaluated jaundice. Now we will be talking about more important chapter, that is cause. So before moving to the cause, I like to talk about few things, okay. So you should be knowing what 1 gram of hemoglobin releases. It releases about 35 mg of bilirubin. Such questions can be asked in your exam. And you also should know that if conjugated bilirubin is more than 10 to 15% of total bilirubin, then it is considered as pathological. Okay. 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 Now let's move on to the causes. Okay. I'll briefly go through it because, like in your exam, in your MCQs, uh, you may be asked about what is the most common cause of jaundice, what is the most common cause of first stage jaundice. So things like this can be asked. So for that, to clear that confusion, let's move on to the causes and let's move to the what pathological. So what are the causes of pathological jaundice? So as you know, this is called as first day jaundice. Okay. Okay. So what causes pathological jaundice? So first day jaundice. What are the cause of first day jaundice? It is generally due to feto-maternal blood group incompatibility. Okay, that means RS incompatibility, and ABO incompatibility. So this is more common cause in the first day. Okay. So what can be other cause of pathological jaundice? Yes, torsus infection. Okay, and some RBC enzyme defects. So if somebody asks you, or if you see a baby with jaundice on the first day, these are the things which you should consider first. Okay, that is G6PD deficiency, pyruvate kinase deficiency. So you have been asked which of the following enzyme deficiency can lead to the jaundice on first day, and G6PD should be your answer. Okay. So after 24 to 72 hours, what is the most common cause? The most common cause will be, yes, this is physiological jaundice. Okay, physiological jaundice. Okay. So other cause may be infection. Okay, that may be congenital or acquired infection. Okay, like say neonatal sepsis. Okay. Can polycythemia? Yes. Can polycythemia cause jaundice? Yes. So in polycythemia, the RBC mass will be high, and when they tend to destroy, then they release bilirubin. Okay. So there is more chance in small for gestational age baby, SGA, small for gestational age baby. Okay. Delayed cord clamping. Okay. Should always think of this. Another important cause is cephalohematoma. Okay. Cephalohematoma, it resolves by itself, but what it can cause is it can give rise to prolonged jaundice also. Sometimes say gut obstruction. So there is gut obstruction, like say in Meconium ileus, Hirschsprung's disease. Okay. So in this condition, it can lead to prolonged jaundice. Now, if jaundice persists for more than 72 hours, okay, after 72 hours, jaundice appears and it prolongs, then what can be the cause? It can be breast milk jaundice, and I'll be talking about this because this sort of question is increasingly being asked in your exams. Another one is breastfeeding jaundice. Okay. Other cause can be hypothyroidism. Okay. Sepsis, neonatal sepsis. Okay. Even biliary atresia. Okay. If a baby is passing clay color stool, deep jaundice, you should always suspect a biliary atresia. Okay. So now I will be talking about few interesting topics. Now let's talk about breast feeding jaundice. What is breastfeeding jaundice and what is breast milk jaundice? Okay, because this question is being asked, and you should know there's a very small difference. Okay, breastfeeding jaundice. So, how does breastfeeding occur? If a mother is not feeding her child properly, okay, so due to decreased breastfeeding, okay, so breastfeeding भनेको चाहिँ feeding नगराएर due to lack of breastfeeding, okay, and it disappears. So when it appears, let's write it again, in the first week. This is important about breastfeeding and breast milk, okay. It appears in the first week and disappears by second or third week, okay. So it will be appearing around first week and disappear about second to third week, okay. So what is the cause? I told you earlier, yes, because decrease intake causes increase in enterohepatic circulation. Yes, okay. Now, what is breast milk jaundice? So breast milk has different different factors. So some of the factors, like some factors like pregnanol and free fatty acids. It is not clear. So these are the typical substances. It is not clear, but some theories say that pregnanol and FFA present in breast milk, they increase beta glucuronidase activity. Okay. So what happens is this conjugated bilirubin will be unconjugated. Okay. It will go to enterohepatic circulation. Okay. So the more important thing here is the timing. So appearance of jaundice by second week. So if it is related to breast milk or breastfeeding, and question something writing like that, and if it in your question it is mentioned appearance by second week there is a peak and may persist up to 3 months. So this is breast milk jaundice, and you should not be confused. Okay.